unmute yourself.
Can you hear me?
Yes, now it's
Okay.
all good.
Okay, great. Thank you so much. Amazing presentations that I've been able to see. Uh, it's just amazing how far neurosurgery and spine surgery has come. It's a great honor to be here with all of my colleagues and my mentors. Today, we'll be talking about patient-specific lumbar interbody fusions. Here are my disclosures. So in terms of objectives of today, we're going to introduce, three types of T-lifts. The MIS T-lift, which a lot of the neurosurgeons are accustomed to. We'll talk about the transcambon percutaneous T-lift and then the transfacet T-lift. We'll talk about indications and limitations of these different types of T-lifts and then introduce the concept of patient-specific T-lifts. And then I'll hope to introduce a current algorithm that I use in trying to decide which TLIF I will use for each patient. So if we look at, how to do a TLIF, a lot of us, at least as neurosurgeons, are very comfortable kind of doing the inside out technique. So you go inside, you do a hemilaminectomy, you find the dura, and you move the thecal sac and you put a cage there. If you put that through a tube, it becomes a little bit more difficult, especially if you're trying to put a big cage. So you have a risk of CSF leak, you have a risk of nerve root injury. Another concept is the what we call a transfacet TLIF. So this is from the outside in. This is keeping the facet joint in the middle of your approach. And for some neurosurgeons, this may be difficult because there are no real landmarks except for really the facet joint, and you could get into some bleeding if you're not careful. And then the third concept is the totally percutaneous transcambon approach. So as all of you guys know, Dr. Cambon was an orthopedic spine surgeon who was very interested in entering into the disc space, and he was doing these percutaneous discectomies. If we look at the boundaries of Cambon's triangle, we see it's the exiting nerve root. Really important to worry about the dorsal root ganglion. We have the SAP and we have the inferior body. So we've done this systematic review of Cambon's triangle, looking at anatomical dissections. We found a few interesting things. We found that as you go caudally in the spine, the area of Cambon's triangle will increase. That doesn't necessarily mean it becomes easier because, as we all know, at L5-S1, we have the iliac crest to deal with. However, as all our endoscopic colleagues will tell you, if you do a foraminoplasty or you drill off this area of the SAP, you can actually double the size of the Cambon's triangle. Now, interestingly, these are anatomical structures, but as surgeons, we deal with pathology. So whenever we have a spondylolisthesis or a disc herniation, actually the area for Cambon's triangle can decrease quite significantly. Now, a lot of this was done using anatomical structures or CT-based anatomy, but really important, as we talked about, is the exiting nerve root. And so I kind of brought expertise as a neurosurgeon into this, where I actually use the commercially available BrainLab software to manually segment out the nerves. This gave us a further insight into the anatomy. We can then use this to plan the side so we can figure out which side the Cambon's triangle is bigger. We can also know before surgery what are some potential traps. So here was a conjoined nerve root. So of course, Cambon's triangle is going to be much smaller. So we're not going to approach the interbody fusion from that side. We also noticed, as we kind of predicted, that if you take the nerve into consideration, the area for Cambon's triangle will actually significantly decrease as well. And then, this is especially for the trainees and so on. I came out of practice and I was very intent on doing transcambon. But then as I learned more, I realized that not every case could be done transcambon. So here's a case where we measured preoperatively and we found that the Cambon's triangle is only 6 millimeters. And so none of the scopes right now will allow you to put a 6 millimeter scope in as an outer diameter. And if we're trying to put a big cage and get good fusion, that's going to be very limiting. So then we started to look at other approaches. This is an approach that was popularized by Dr. Ray at WashU, and this is what we call the transfacet corridor. So if you look here, this is caudal, this is rostral, this is the IAP, this is the SAP. If you keep these two in your middle of your corridor, this is your working corridor right here. And you can actually do this surgery without finding the nerve. And so this is kind of a orthopedic type surgery where I'm able to now put a much bigger cage, not worry about the nerves. And then if I need to go in and do a decompression, I can go ahead and do that. And so this is kind of what we're doing now. The same patients are getting these MRIs right now, and we're actually able to plan out the exact trajectory. We found that if you stay within the facet joint, you can avoid the nervous structures. And we see that in most cases, the transfacet corridor is going to be significantly bigger than the Camden's triangle. And interestingly, the transfacet area increases similar to Camden's triangle as you move caudal into the in the spine. But more interestingly is that if you have pathology such as a spondylolisthesis, because the joint is diastased, that actually area will increase. So now as surgeons, as we know, we deal with pathology, the pathology that we deal with will actually make the transfacet pathway safer. And now, significantly, the limiting factor is no longer the pathway or the nerves, but actually the posterior disc height. So you can see here that the area entering into the disc is bigger than the posterior disc height using the transfacet approach. So here's a case. It's a 30-year-old gentleman with a grade 1, grade 2 spondylolisthesis. You see here, due to his vascular anatomy and psoas anatomy, not a very good A-lift candidate or O-lift candidate. You could possibly think about doing lateral. He didn't really want to have a lateral surgery. So we put in the screws, and then we got a CT scan. And then we merged the CT scan to the preoperative MRI that was segmented out. And then we can go through the facet joint, avoiding the traversing nerve root, avoiding the exiting nerve root. And then you can see here, while we're under the microscope, we have this heads-up display, so I know exactly where I am. And this is kind of, augmented reality in the microscope using the spine. So right now, we're manually segmenting out the nerves, but we're working on an automated segmentation program in the near future. Hopefully, my hope is actually not to look at the screen, but actually look through the patient. And I hope I can present that next year. In terms of decompression, so, the transcambin approach is not the best for a decompression. With the transfacet approach, you can wand your tube more medially and do a decompression if needed. And we found that, it does make a difference. So patients that have the percutaneous TLIF use about 40% less opioids. And so having this in your armamentarium is important. And so actually that's what kind of got me into endoscopy, is to try to bridge the gap between my percutaneous TLIF and my MIS TLIF, either inside out or outside in. And you can see here with the endoscope, as we know, we can do a nice decompression. Now we've talked a lot about patient-specific pathways into the disc, but now we're also looking at patient-specific implants. So these are implants that are done looking at the preoperative. Unfortunately, this is right now CT-based, so but those subset of patients that have CTs for some reason, we can design the perfect implant. And you can see here, it molds very nice to the end plates. And so then we have very good ability for fusion. And so this is things that we're working on now, and we've had some really good success with this as well. So here's another case. This is another patient with a grade 1 spondylolisthesis. We do our mapping. We find that the Camden's approach is 7 millimeters, which is a little too small for our comfort. So then we do the transfacet. We see we have 11 millimeters. And so then we're able to go through the transfacet pathway safely, and we're able to put actually a 3-dimensionally expanding tube. So right now, our current algorithm is if we have multi-level or significant deformity, I think it's really important for us to know the limitations of what we do. And so I do a lot of open or MIS or hybrid anterolateral, either A lifts or O lifts, or then my newest favorite thing is the prone lateral. If it's not a multi-level and we look that we're doing 1 or 2 levels, we do the segmentation and we say, you know, is Camden's triangle big enough? And there's different definitions of what big enough is. If it is not big enough, then we're going to try to use the transfacet TLIF. If there's a facet cyst and so on, we can always do a decompression as well. If the Camden's triangle is big enough, we need to know whether we need to do a direct decompression or not. If we don't have to do a decompression, I think those cases are very good for the transcambin approach. I still use that approach. If we do need to do a direct decompression, we can either do a transfacet TLIF with a decompression, or we can do a transcambin approach with an endoscopic decompression. And so to conclude, I think the TLIF is a very powerful technique. It allows you, if you need to do direct decompression, it can correct the spondylolisthesis and have good fusion. I think we really need to, just like all the other presenters have shown, you know, medicine is no longer a cookie cutter field. We need to have patient-specific and pathology-specific planning, and that's so important. And with that, I'll end. Thank you so much.
Many thanks for your presentation. It was great to see where the TLIF is going. It's definitely the one of the direction that we see developing, and you are developing that now. Thank you so much.